Morning everyone, thanks for bearing with us. We're just going to wait a few more minutes. Abeyratne's going to join us, but I'm going to get the ball rolling here because I think it's worth starting the conversation. We have a brilliant panel here for you today. So hopefully you all feel like you're in the right place. Today's panel event is Beyond Disparities, Labour's Vision for Health Equity. You're all very welcome here, the few brave folks who've overcome their hangovers from whatever karaoke event they were participating in last night to join us here for the morning. And let me remind everyone that there are some breakfast items available behind you. Do help yourselves to those. So I think this is going to be a crucially important and I think quite a timely conversation to be having here as we see a general election looming, but also in the context of a real variety of looming health inequalities, pervasive health inequalities that affect lives of many communities through our countries. The big subject for us today is to talk about what we think potential Labour government's response or approach to addressing those inequalities might be. I'm Simon Kay. I'm the Director of Policy at the think tank Reform. I've been going out of my way to use the words think tank reform. Some people could treat me a bit weirdly when I just said Simon Kay from Reform. I don't know why. I don't have any idea why that at this particular. Anyway, so I've been saying think tank reform. One of the big project areas that we've been working on for some time now at Reform is a program called Reimagining Health. And one of the major motivations for that work is this challenge surrounding health inequalities. These are inequalities that persist in terms of geography, in terms of socioeconomic status, and they're also spatial across different parts of the UK and affect people in terms of their demographic differences and ethnicities as well. So there's all sorts of different dividing lines along which we can see different outcomes for different people in this country. In February last year, the NHS Race and Health Observatory published a review that found, and I quote, overwhelming evidence of vast and persistent health inequalities between different ethnic groups in the UK, for example. And what was really striking about that published review was that was not only in terms of health outcomes, but in terms of health care, in terms of the way people were treated when they tried to access services from our health system, which is starkly different sometimes for people from different ethnic backgrounds in our country. Before COVID, the Office for National Statistics, the kind of the gold standard for understanding what's going on statistically with our country, found a 19-year gap in healthy life expectancy between the wealthiest and the poorest parts of our country, a 19-year gap. And when I read that for the first time, I was absolutely convinced it had to be a typo. But that's an enormous difference, and it goes beyond statistics. That is a difference that means that if you happen to be poorer, you will have worse health outcomes. You will get sick more and more often and earlier. You will have a life-changing condition that might affect the quality of your life over a long period, and you may well die sooner as well. That's our country in 2023, a 19-year gap. So in the context of these stark inequalities, as I've just put it, there was of course some consternation when a promised health disparities white paper never quite materialised from this government. Elements of that plan made their way into policy that has since been published. But there's still so much to address, and there's so much to talk about when it comes to health inequalities, and so it seems like a really important moment to go beyond disparities and to talk about the future of health policy in our country when it comes to inequalities. And I think our brilliant panel today gives us a genuine opportunity to have a productive conversation, a useful conversation about these issues. So to my left, Rachel Sylvester is of course one of the UK's foremost political journalists and is moreover the chair of the Current Times Health Commission. Dr. Abeyratne is the Director of Health Equality and Inclusion at University Hospitals Leicester, and Professor Manish Pareek is Professor of Infectious Diseases at the University of Leicester and an international expert on public health research into ethnic minority health. And I should add that our friends joining us from Leicester and this whole event is happening thanks to our brilliant partners at the University of Leicester's Institute for Policy. Leicester research, I'm told, was the first to demonstrate that COVID was having a disproportionate impact on ethnic minority groups, such an important factor in what we're here to discuss today. So that's more than enough from me. I want to make some good time for questions from our brave early morning audience as well. So I'm going to hand straight over to you, Rachel, if I may.
Yeah, thanks, Simon. I thought it was worth just starting by setting out a few of the facts, which really are shocking. As Simon said, that 19-year gap in healthy life expectancy. But that's not all. So men in the poorest areas died 10 years earlier than men in the richest. Women, almost 8 years. There's also been a significant decrease in life expectancy between 2015 to 2017 and 2018 to 2020. So this situation is getting worse. Women in the most deprived areas live less than 2/3 of their life in good health, compared to more than 4/5 in the least deprived. And of course, black women are 4 times more likely to die in childbirth than white women. So this is a mixture of the way in which the health service and the system deals with people, but also the environment in which people live. And of course, the economic cost is absolutely enormous, as well as the personal and social cost. It's just such a huge waste. Imagine if all the people who are living 19 years less were in good health for the same amount of time. They'd be working longer, they'd be living better lives, happier, healthier, more prosperous, and that would be good for the country, good for communities, and as well as good for individuals. So for me, this whole issue really reinforces the need to see health in its widest context. I think too often with health policy in this country is seen as basically a hospital policy or a sickness policy. It's the National Hospital Service, the National Sickness Service really, rather than the National Health Service. And what we've been hearing repeatedly on the Times Health Commission is we need to think of it in this broader sense. So it's about the context in which people live, their homes, their food, their lifestyle, as well as what to do when they get ill. You can't just deal with the problem, symptoms of the problem, you have to deal with the underlying causes. So if you think about housing, obviously there's a huge impact on the terrible stories we've read about children dying because of the mould in their homes. Similarly, on there's smoking, there's big inequalities on smoking take-up rates. So I think it's really interesting there's now cross-party agreement about phasing out smoking over the next generation, which for me is a good thing. I'd also like to highlight the importance of the food environment. I think some of those obesity, the differential in obesity rates is for me really shocking as well. So it's appalling that children in the poorest areas are 5 times more likely to be severely obese as the richest by the time they get to the end of primary school. And even in reception, at the start of school, children in the poorest areas are 4 times more likely to be severely obese. This isn't their fault or their family's fault. It's the environment in which they're growing up. So I think it's really important that governments are less afraid of trying to level the playing field on health and on food. There's a kind of phobia about the idea of the nanny state and governments intervening, but actually I'm not sure that it's not a negative thing to intervene to help give people a genuine choice over the decisions that they make. Too often the playing field is tipped, so it's very hard for people to buy healthy food in the poorest areas. It's very hard for people to cook if they can't afford the energy. People aren't learning how to cook at school. So there are all kinds of things that need to change that go beyond the kind of outcomes that we're seeing and the sort of health disparities here. It's about the whole culture and context in which we live.
Thank you so much. Ruth.
Thank you. Good morning, everyone. So I'm Rue, and as well as being Director of Health, Equality and Inclusion, I'm also a geriatrician, so I look after older adults in our acute services. So I work at the University Hospitals of Leicester. Leicester is one of the UK's only plural cities. We don't have an ethnic majority in Leicester, and we also have very high rates of deprivation within our populations and communities. When I work with my colleagues to start to talk about how we address health inequalities, the first thing that I say is that we know that health inequality is avoidable. So if we do nothing to address an avoidable injustice, then we are complicit in the entrenching and embedding of that injustice, and that's an unacceptable position for me to be in, especially as a clinician. A woman of my age in the city of Leicester, from one of our most deprived communities, can expect 12 more years of healthy life expectancy, which again is just a very stark contrast to where I see myself as an individual. So what are we doing at the University of Leicester? My mandate predominantly comes from NHS England. There is a mandate around access, experience and outcomes that Simon and Rachel have already alluded to. When the white paper wasn't published, what we then lost was a sense of priority around delivering justice in access, experience and outcomes. And what we really need is a commitment to that, and the permission that that then gives us to put that at the top of the list of priorities around how we deliver healthcare to all of our communities. So as a clinician, we take direction from that, and we recognise that as it is written into the NHS Constitution, that that is what we are here to do. When we say we deliver healthcare explicitly for all. And that's a difficult position for us to be in when we hear the stark statistics that Rachel has spoken about. Can we actually honestly say that we are doing that? Certainly at Leicester, and the work that Manish and colleagues are doing, we are taking intentional steps to address disparities, but they are broader than the healthcare that we deliver. So we know that healthcare only accounts for 20% of inequalities. So we have a role to play in that broader system and those wider determinants around housing, employment, the environment people are working in. And as an organisation, we recognise that we have a responsibility around that. But therein, there is a challenge for us to start doing things differently, to think about how we can deliver models of healthcare and how we can be a partner in that system in different ways to challenge the conventional way of doing things. And we're really interested in working with our partners, the university being a strong partner of ours and others, to start thinking about how we bring communities into that conversation, how we put ourselves in the heart of the most deprived and in need communities, and how we work with them to understand the positions that they are in. As a woman of colour, I do not know what it feels like for another woman of colour. I have to hear their voices, and that's one of the fundamental aspects of my job, and bringing that into a hospital environment where my colleagues are tired, they are working at the limits of their potential because we are constrained. So how do we bring that voice into the room and innovate with our communities and our clinicians and colleagues who are all desperate to do more? And the final thing that I just wanted to touch on is around what should we expect. So the health service, and as a clinician, what I'm used to saying is that we do our best at all of the times, that we are with patients and that we are working with communities. But actually, what we need to start to do is to expect better, because we are doing our best, but how do we change best into better for more people? We have a lot of work to do at UHL, at University Hospitals of Leicester, but I do think that with partnership working, particularly with our integrated care system colleagues and our academic colleagues, we have shown, and Manish will talk a bit more about, the ways in which we can get creative and be innovative around addressing health inequalities. Thank you for having me.
That's so helpful. Thank you, Ruaridh. Manish?
Thanks, Simon. Good morning, everyone. So I'm an infectious physician and clinical academic, so I split my time about 50-50. I've been working in the area of health inequalities for the last...
Can you use the mic? Oh yeah, lean into it. Sorry, Manish.
So I've been working in the area of health inequalities for the last 15 years or so, and much of what we've seen during the COVID pandemic could have well been predicted. Since 2010, we've seen progressive worsening in health outcomes, but it always hasn't been this way. Prior to 2010, we did see some improvement. The last decade, we've seen a slowing and reversing of some of the critical health outcomes, but not just in terms of increased risks of death, but also, as Rachel was saying, in terms of life lived disability or poor health, which is really important, because to me one of the critical things is that health has always been considered as a separate entity to everything else. And actually health is critical to the success of the country. You have an unhealthy country, you don't have a successful country. So actually health has to be integrated. So when you have health inequalities, what you have is actually poorer outcomes across all aspects of society. And so therefore, having a system-wide approach relating to not just the NHS, because the NHS has become very reactive. It's about waiting lists, it's about waiting times. It's about thinking about prevention, trying to reduce those areas that we can try and prevent, so obesity, other aspects of mental health, for example. But also think about housing, transport, schooling, all of those things which, particularly at early life, because those things are then embedded from an early life through people's longitudinal lifetime experiences. The other thing to say as an academic is that, for us, data is key, and we are really replete. We have great data in the UK around health outcomes. We have a joined up, unified health system. So we should use that data to try and address the concerns that we have. Which are the health concerns in different areas? The problem in Liverpool may be a different problem in North London versus Leicester. But if we can try and understand what the health issues are for different communities, we can then start to consider what the potential implementation of interventions might be. Otherwise we're going blind, and we're going to have a top-down central approach, which to me is fine. We need central push, but it has to be nuanced for the local communities. And actually the local communities are where things will really be delivered. Consider COVID. When we had COVID, at the start of the pandemic, how was public health messaging delivered? It was delivered through those 5 o'clock briefings by Boris Johnson or by the CMO or others. But do you think that individuals living in the most deprived, ethnically diverse communities were listening to Boris Johnson at that time? Probably not. They were probably working as key workers, out working when some of us could have been at home. So actually the delivery of public health messaging was poor from the outset. We said that, and actually it then transpired. The ethnic disparities that we saw coming out very early on, and actually colleagues and I wrote the first articles on this back in April 2020, and we could have foreseen them because we hadn't thought about the communities. And that's partly because some of the funding at local level has been removed for public health. It's also because there's been a top-down approach, and if we can push for a much more community-led drive of identifying what the health issues are, but also coming up with solutions together, which aren't just top-down. The other thing to say is that the NHS has obviously a really important role to play in delivering healthcare, but it is an anchor institution in all of our systems, GPs, hospitals, pharmacy. But think about the delivery of healthcare. We need to think a little bit more cleverly at how we deliver both preventative and reactive healthcare, not just hospitals or GPs, but think about pharmacy, think about employers. Why are we not working much more closely with them? In Leicester, we now started working much more closely with third sector organisations, and also we started working with employers to deliver health screening inspections, because we know that sometimes the most deprived individuals don't actually access their GP or the hospital. They can't afford to, they have to work. If they don't go to work, they'll lose a day's work. But their employers can be incentivized to deliver some of that healthcare for us. And that's where we need to start thinking. So I think health inequalities, but I don't think it's all bad news. I think we can change this. We have seen improvements prior to 2010. So I think there is definitely an opportunity to go forward and start to change our mindset. Thank you.
Thank you so much. Really useful and insightful opening comments. I'm just going to ask a few questions myself. Apologies everyone about the herd of elephants that's moving around outside. Is that, oh, Debbie's here. Hello, thanks for joining us. Debbie, you're actually just in time, if you can catch your breath, to give an opening statement. What I can do, I can give you a really long intro. Would that be helpful?
Carry on with the long intro.
All right, I'll do that. So Debbie has joined us, everyone. She's the MP, of course, for Oldham East and Saddleworth. She is the chair of the Health in All Policies APPG, among a number of other APPGs at various points as well, and has been a champion for the cause of addressing health inequalities over many decades in a variety of roles, both within and beyond politics as well. Is that fair to say?
It is indeed.
And most recently has produced a documentary film called The Unequal Pandemic. That came out this year, didn't it?
It did, a couple of weeks ago.
Yeah, which is, I'm told, brilliant. I haven't been able to see it myself, but well worth catching. Debbie, yeah, if you caught your breath.
Absolutely, I have caught my breath. And first of all, huge apologies. I left at 5 to 7 this morning, so as I say, huge apologies on behalf of the M62. The reason I got into politics was to focus on inequality. So I was a public health consultant, public health academic here in Liverpool. And as anybody that knows anything about health inequalities will know, you need to focus upstream to whether policies are being developed to make sure that you can make that difference. And what we know from all the evidence around inequalities, the key determinants of health and the key drivers of inequalities are on socioeconomic inequalities. If anybody here has read The Spirit Level? Yeah? So, that is, if you haven't read it, do. It's a nice, easy read. Kate Pickett, who was here, in fact I think she was having a session in this room itself yesterday. Kate Pickett, Richard Wilkinson wrote that book, and basically it says that the narrower the gap between the rich and poor, the better we all do, both in terms of increased life expectancy, better mental health, better social mobility, educational attainment, less crime, greater trust between communities. All the dimensions, everybody benefits. It's not just those on the lowest incomes. And then, of course, we had the fantastic publication from Professor Smikle Marmot just before 2010, the 2010 election, Fair Lives, Healthy Society. Again, a really, really good read, who set out the 6 objectives if we are going to make that difference in inequalities. And of course, the Labour government did make a difference. But what we've seen, as again, Michael's review after 10 years into the progress made against the objectives that he said, we're actually going backwards. And particularly in deprived areas where life expectancy is actually declining. We are one of 3 countries in developed economies where our life expectancy is going backwards. There isn't a peak life expectancy. It is actually declining. Another important point that has been mentioned, and in addition to Michael, Claire Bamburgh, who's also here yesterday, has emphasised the importance of place. So equivalent deprivation areas in the north do worse than the same levels of deprivation in the south. And I think that we really need to reassess our understanding of the health divide. And many of you will know Margaret Whitehead, who in the 80s, after the Black Report, published her very, very important paper. Margaret is the W.H. Duncan first public health officer in the country here in Liverpool. And she's the Duncan professor, and she showed for the first time this health divide, this north-south health divide, and it's still here. What my film tried to show was not only what happened during the pandemic, it showed the mirroring of cases and deaths from COVID, mirrored the areas with structural inequalities. So the northwest, the northeast were particularly affected. People of colour, disabled people were also more likely to be affected. Some appalling aspects of our society. So I was delighted with all that background and context. Sorry if I've droned on and other people have covered some of that already. But what the health mission that was set out a few months ago, I'm a backbench MP, everybody will be aware of that, but I was pleased about this because it did emphasise the importance of cross-departmental working, to have a health and all policies approach. So it's not just a question. Health, as we know, isn't just a question of the NHS. It's not the Department of Health and Social Care. It is every single department. And I was also very pleased to see that the commitment that after every fiscal event there will be, or with every fiscal event, there will be a publication in terms of the impacts on health and on inequality. And that's so important. Over the last few years, after any budget, there's a finance bill, and I slap an amendment on making sure that the Chancellor is going to be publishing a report onto the impact of the fiscal decisions that he has made on inequalities and subsequently on health, and ultimately that affects our demand of health services. So I was really pleased around that. The focus on prevention, and particularly in terms of primary care emphasis, and also making England a market country. Who could not want that? It's absolutely fantastic what's being suggested. Many other things, aspects of the health mission, and I'm looking forward to seeing the detail of that developed as we go forward. So that's, I think we're definitely moving in the right direction.
Thank you so much, Debbie. Thanks so much for doing that. Having rushed in, do appreciate that. So just a few quick things to pick up on some of those themes that I think have emerged really consistently across all of everyone's comments so far. Hopefully, can everyone still hear me okay? Excellent. It is a bit loud out there, but that's normal at this point. So, Rachel, one of the really interesting potential tensions here, is between the top-down and the bottom-up. So I think you were right. So there's this idea that at the moment we have this so-called National Sickness Service. That's kind of a centralised affair. There needs to be a better emphasis on public health to help address some of these inequalities that we've been talking about. But some of the policies we're seeing emerge on a cross-party basis, like a smoking ban, the progressive smoking ban, if that isn't a top-down measure, then nothing is. So is there another family of public health intervention that you're starting to hear about in the Commission, perhaps, that works in a more bottom-up way? Because I think some of the evidence from New Zealand is that actually smoking bans affect ethnic minority communities very differently to how they affect people in the mainstream community.
That's interesting. I think actually you need both. So you can't have everything imposed top down, but equally you can't have national governments abdicating responsibility for some of these issues, because it's only going to work. What the companies have been saying to us, food companies for example, is they don't want to act unilaterally. They'll only act if there's a kind of level playing field introduced through legislation. But that's also, I think Debbie's absolutely right, every area, and Manish made the same point, everyone's made Ruaridh as well, that every area, even every little ward, is very different. So you need to have some decisions made locally. I think the ICS's integrated care systems have a potential to have that kind of devolved power, but at the moment they seem to be working in quite a hodgepodge way or unequal way. But I think what happened in Manchester, where greater power over health was devolved, they have managed to reverse this kind of fall in life expectancy. I know it's early days, but they have done a lot of sort of localised health, public health decisions that do seem to have made a difference. And also on mental health, things like the Be Well mental health survey of all young people, which has then been used to identify really local projects that could help with particular, even at a street level, for kids who need, kids in a particular school say they've got nowhere to play after school, and kids in another school say they really want something to do with drama. They've been able to target projects very specifically based on what the children have been saying. But I think ultimately it's got to be almost evolving right down to the individual citizen. So you've got to have the three levels so that people feel they have more power over their own health and their own life. Obviously, if you're very poor, you have much less power. But I think using data and information is a way to empower individuals in the system as well.
That's really helpful. Thank you. Rue, I was struck by your thoughts about the importance of co-producing, if that's the right word, some of this stuff with the communities in question that are having a much worse time in terms of health outcomes and healthcare. Now, something that I've been exploring a bit in my research over the years, I do a lot of sort of community power and localism, is that the communities that are most suspicious of outreach efforts from big institutions like the NHS or local government or national government are often ethnic minority communities. Is there anything in your experience that helps us to overcome that reluctance and that distrust, sometimes very well-founded distrust?
Thank you. It's a really important question, and it is a really important way for us to start to be. It's an incredible challenge, and I think the first step that we have tried to take is to recognise that trust is low. So we go out to communities, and we do this in person. So I will go out, my colleagues will go out, and one of the first things that we have to acknowledge is that when people say to us, why should we believe you? We haven't got a specific answer to that question. What we have to keep saying is we are showing up, and we will continue to show up. So we've done work with a charity in the middle of Leicester that works with our most deprived populations. They run a food bank where there is an incredible attendance rate, but when we go there, what we see is that the people who attend that food bank are as interested in their own health as anyone else. What they need, though, is us to be present to navigate some of the complexities of our systems, to take away some of the myths, and to recognise that we don't always get it right. And that would be the other thing. So some organisational humility around the fact that we have made mistakes and that we will continue to learn. The other thing that I think is really important, and I alluded to this in my opening remarks, is to not make assumptions about how much we understand what it means to be underserved or underprivileged. And those are difficult conversations to have. So one of the challenges that we have, for example, in Leicester, is that our workforce, we have nearly 20,000 employees, we have a plural city with no ethnic majority, and our workforce is part of that community. But we know from national data that our workforce experiences discrimination within our organisations. So what conversations are we having within our organisations to deconstruct some of those barriers? They are difficult conversations, but we have to start to be more progressive, more open and more honest. And I certainly think we're doing that at UHL. And then you start to see trust start to build, and to see that actually when you go into that space and you go into that community, you have a more open and honest dialogue. And what you start to get from dialogue is solutions rather than assumptions.
Right, which is a big step to take. Manish, you might have some views on this as well. I'm also very interested by this idea about how the very communication around public health broke down and failed to satisfy some of our requirements for reaching different communities in the midst of the pandemic, probably contributed to the unequal outcomes we saw during the pandemic. What does good practice look like?
Well, I mean, I think, Simon, as Ruaridh was saying, you have to build relationships and trust. And, we've been working this with migrant and ethnic minority and deprived communities for 15 years, and we don't see this as a one-stop. With communities, we don't want them to think we're just parachuting in, doing something and disappearing, no, to affect change. So 15 years it's taken to develop the trust and the relationships which have started to bear some fruit, but also we understand that that trust is not just for those individuals that we meet at that specific moment. Those individuals then go back into their communities to pass on the messages that we're trying to deliver, whether they be health or economic, etc. In terms of the public health messaging, very early on, Simon, I remember speaking to one of my colleagues at one of the other universities, and we said, public health messaging is just not right. It is not right, and there's going to be an issue here. And we said this very early, and I think it was February 2020. And I think that was borne out. And actually, because I was working on the COVID wards, and we were seeing disproportionate high numbers of ethnic minorities coming in, young men and women who were disproportionately becoming sick. And I still remember those days, and I still think that if we had been proactive in the messaging, but also thought a little bit more carefully about who those groups are, the data was already there about who was at risk. We just hadn't looked at the data. If you look, no academics ever do anything very, very novel, to be honest. Because if you look back far enough, someone's already done it. And if you look back at flu pandemics, previously, even seasonal flu, ethnic minorities, deprived communities, particularly individuals with comorbidities, always had worse outcomes. We just had to look, but we hadn't looked. So therefore, we weren't prepared. Because we weren't prepared, we hadn't prepared our communities. And that's why we saw disproportionate impact. But it wasn't just the communities, don't forget healthcare workers from ethnic minorities. Now, I lead a study called UK Reach, which is now probably one of the world's largest studies of ethnic minority healthcare workers. And we see a lot of information, a lot of experiences during the pandemic, particularly around PPE access, about access to information about redeployment, which, bear in mind, was obviously in the context of the pandemic, show us that there was, as Ruaridh was saying, discrimination and harassment around those aspects. So I think the public health messaging has to be consistent, ongoing, incremental. It has to be, you have to build trust, and don't expect that this will be an easy work. This will take years to build.
Did you want to comment on that?
I absolutely agree. I was just thinking that in the film we actually go back as far as the 1918 flu pandemic, which showed exactly the same thing. You can see exactly the same patterns. And what concerns me is that we address them and then we go back, we address them and we go back, and we still are in this cycle. The reason I made this film was to make sure that we just didn't go back to normal. We learned the lessons. It was so in our face. Everybody was affected, and not to even conceive that we'll just go back to how things were and wait for the next time for exactly the same thing to happen. We just cannot allow that to happen. So Abeyratne from the Race and Health Observatory, something he said, a line in the film that he said is, we knew who was going to be affected. We knew that there were multi-generational households, the type of work that was key workers being done, but we haven't been asking why. And that comes down to the structural racism within our society. We have to face up that Black Lives Matter isn't just an issue for the States, it's for us as well. And we're just not facing up to it. It is just not good enough. We have to take action. The other aspect was in terms of power, because as you rightly said, Manish, it was also clinicians. Ethnic minority clinicians were more likely to die. Rachel Clark actually provided evidence. She was also on COVID wards, and she was talking about the clinicians that were affected and what PPE was provided to them and what was provided to her. There was also other issues in terms of gender. So the PPE, to have a fit test, the PPE that was provided was commissioned for men. So there were also issues for women. But on the ethnic minority issue, it's just absolutely shameful. And we've got to learn from this and do better.
But the masks were commissioned for men, so they didn't
fit. Rachel was told, if you want to get your own proper fitting mask, you can go on Amazon and get them for 300. It's just not good enough.
It's probably not very good for a chair to show shock and bore.
Well, I can tell you some more, but I won't.
No, thank you so much. Look, I could go on all day, but it's not fair on the audience, so I'm going to hand straight over to you fine folks. So please do put your hands up if you have any questions. Yes, lady here at the front end here. Yeah.
Hi, I'm Antonia All from Impact on Urban Health. We're part of the Guys and St Thomas's Foundation, based in South London, and seeking to promote health equity, particularly in South London boroughs, and beyond as well. We work with community groups, funding community research and different forms of research, up to influencing multinationals to reformulate food. So quite wide-reaching. But I was just wondering, the panellists, some of you have mentioned partnerships and third sector and charities. So what role do you think that philanthropy can play, like in particular funders that are able to mobilise resources to kind of promote really effective partnership work?
Thank you. Let's take a few more. Yes, please. Just behind you there, dear. Thank you.
It's going to be a little bit similar, but I'm Nicole from Breast Cancer Now, and we've been working a lot looking into the breast screening program. Uptake has been historical lows, and the inequalities gap is increasing since the start of the pandemic. And we're trying to look into that and address the many ways that the program just isn't accessible to a lot of women. And there are multiple practical, financial, social, cultural barriers that keep women away. But one thing that we're really struggling in addressing this is silo working at a local level and also at a national level, where you have locally just different teams commissioning different services. Doesn't seem to be a lot of conversations or communications, and even at a national level you have NHS England cancer team, NHS England cancer screening team, and different one for health disparities, and just no collaboration. So looking at the ICS model and the partnerships, where we want to get to, how do we get people to work together? What's the role of leadership and clear responsibilities?
Thank you. Should we take one more? There's a gentleman right at the very back there. There we go. Thanks, India.
Morning, everybody. My name is Ishmael from MainCap. I'm the Partnership and Government Engagement Officer. So our charity is helping people with learning disabilities and families. My question is, where in my role I get working with lots of different MPs and talking about issues about the charities concerning about healthcare. So making sure that how MPs can turn things, doing a different way of making better healthcare, and how to help around with organisations like MainCap, where we are campaigning around the best healthcare for people with learning disabilities and families. Thank you.
Yeah, thank you. I'll turn straight back to you, I mean, particularly on that second question. I mean, you mentioned the importance of health in all policies, which is quite an abstract concept, except for those of us in the kind of nerdy policy world. But it seems to be really relevant to that point about, well, how do we overcome the silos that seem to be disrupting outcomes?
Well, in the same way that what has been proposed at a governmental level about intergovernmental working and cross-departmental working, I would hope that that would also be something that was, if not encouraged, that perhaps some very clear guidance could be put into how, in terms of how that expectations about how that would happen at a local level as well. It is so counterproductive. It really is, and also wasteful. So sometimes people could be working, as you say, in silos, possibly in the same way. So this is something I would really like to see. But my very first public health job was actually in Knowsley, as part of the Health for All movement, and I remember that was what we encouraged. And you could do huge stuff. You really could make a difference, and have it at the national level as well. You really can make differences. So absolutely. In terms of secondary breast cancer, it also needs for us, and it goes back to what we were talking about just now. We need to be thinking about who are the different population groups that are going to be affected. What are the protocols that we are using? How are we making sure that information is available to them? The other aspect I picked up on in terms of workers as well, that reflect the communities that they want to serve and so on. So there's lots of different things that we can be doing and should be doing, and that I don't think costs a lot of money. It's a question of different ways of working.
Rachel, we've had some questions here about what politicians could do differently, the way that public services could join up more. Have you been hearing things about that as part of your commission evidence? About joined up and more kind of localised, place-based approaches?
Yeah, definitely. I think that's incredibly important, and sort of stopping. I think sometimes Whitehall is so disruptive, the way in which it's all separated into the departments that actually don't connect. And for me, the solution to that is to go back to the patient. So there's arguments about data. Who owns the medical records? It should be the patient. So it should be the individual, the citizen. And also, I think bringing in organisations like the lady from at the front there talking about impact. Yeah. So it's, I think, bringing in other organisations beyond government. Everyone's got to pull their weight here. So companies, philanthropy, charities. This isn't something that government can just dictate in its sort of old-fashioned way of working. You've got to have a kind of really genuinely holistic approach.
I think that sort of takes us to another aspect of the questions we just heard, which is to do with making those partnerships, particularly with communities and third sector organisations, work well. This could be something that's relevant to both of you. Ruaridh, do you have a view on that?
I do, yes I do. Yes, so the third sector and the partnership and the community working is so vital to this work for it to succeed. And I referenced earlier about the assumptions that we make and then we get to solutions that aren't informed. Without any doubt, we need to be bringing in and stepping into that space to think about how we create and craft those relationships. But it is difficult work, and I think that point about it takes time is really important. So for example, at UHL, we are trying to develop, the name is to be confirmed, but something around a health justice network or partnership, where we give space to different communities to be telling us and informing us about the impacts that our decisions around healthcare delivery are having for that community. The question that we ask ourselves is, how do we know that we've got the right people in the room? And we have to ask the community that question. We have to listen. So when, for example, the Somali community tells us that written communication doesn't work for them, we have to respond to that. That's our duty of care. But it won't be the same for a different group. And so ensuring that we have developed enough of a network, that we are trusted in enough spaces, will take time. I think the other thing for us to do is to think about the language. So the connotations of a voluntary service or a community organisation. What we're actually talking about is experts in their field, and we have to start to recognise them as such and bring them into our conversations as such. So we are trying to do that in a proactive way, and again, we are learning as we go. And I think that one of the things that we need to be robust around is how we develop that learning, share that learning, and then grow from that learning. But certainly recognising those groups and individuals as experts is a big step.
It's really interesting, and that point about expertise I think is crucial, because we're in an environment when we talk about healthcare where medical expertise is obviously prized, it's massively a priority, but do we sometimes, Manish, deprioritise other kinds of expertise, more localised expertise, community expertise, social expertise, that also should play a role?
Yeah, I think that's been a historic thing, that medical expertise is seeming to be more important than community expertise as an example. And just returning to Rue's example, actually delivery of much of what we've done locally has only really been possible because of the community partnerships. And I think really understanding that without those community organisations, third sector organisations, we would not have been able to make inroads, because actually the trust issue is critical to all of this. Without building that trust, you don't even open the door to the next aspect, which is starting to deliver healthcare, information, etc. So community organisations are key, and actually now I very much go into all of our conversations with an understanding that I know nothing and they know everything, and I go into understanding and learning from them, and it's very much an equitable partnership, and actually making sure funding is a real critical thing for many of the community organisations, often very poorly funded, to make sure that actually they're getting requisite work and money to actually do the work that they're doing, because at the moment they aren't, and that's a real problem. I just wanted to read about the silo. I think that's a really critical thing. Personal examples, I work in infectious diseases. We deliver screening programs for infections like tuberculosis and HIV and viral hepatitis, and there's always been this siloing of the different conditions so that different people will look after and I never found that really understandable. Patients didn't like it. They didn't like going to 4 different physicians for 4 different conditions. And why don't we just do everything in one go? We should move to the patient and around the patient rather than asking them to go to 4 different places. And actually in Leicester we've now done that. And what was initially a little bit of resistance has now become routine care. So actually if you can push and have the community's backup, actually you can make real change.
Well, I think that's an important note, and it's one we're going to have to end on, I'm afraid, everyone. I found that an incredibly interesting and helpful conversation, and at least I'm happy. I hope you found it useful too. Huge thanks to our partners for making this event possible. At the University of Leicester supported this event, and please join me in thanking our brilliant panel for that really helpful.